told me before we go on air that there's also an initiative of actually establishing a health economics department that will be established within every hospital. Now, how can this be beneficial, and what exactly does it mean? I mean, you're a lecturer on health policy and health economics, but what can a health economics department help and do at hospitals, and how can it benefit the Egyptian citizen and patient?
Okay, so let's start that Ministry of Health recently announced Health Economics Department, and we are currently trying to add health economics as a specialty for pharmacists. So health economics was established actually in Egypt, the pioneer country in the Middle East and Africa. We're the first country to initiate EUNET. By law, we do have a health economics department inside the Unified Purchase Authority, the UPA, and we do have a health economics unit inside each health entity. We're talking about the Universal Health Insurance Organization, we're talking about Egyptian Health Authority, the old universal coverage, and even for the specialized medical center. However, what we are discussing currently is having a subsidiary units of health economics inside each hospital. The centralized one inside Ministry of Health, they are responsible for the general health policy and efficiency control for both medications and the patient journey, all the equipments of patient journey. We're talking about diagnostics, follow-up, we're talking about operations and all interventions included in the treatment journey. However, the subsidiary health economist, he will be responsible for costing, for example. And for costing, it's very important because we were all the time purchasing medications based on price.
Yes.
However, currently we are changing the laws to be based on cost. The big difference between price and cost is regardless the price of a medication, whether it will be good value for money or not. Sometimes you are purchasing a very cheap needle, for example, for a syringe, but the nurse cannot actually install it correctly and they are consuming 2 or 3. So you can purchase it double the price, but it will be installed from the first time. So that's the main difference between what we are calling the price and cost. So health economics will be responsible for establishing good costing strategy for hospitals, even if the price is higher. However, it's cost beneficial. Secondly, they will be responsible for the capitation costing per person, whether the individuals are treating with the right intervention or not, reporting back the cost effectiveness data to the central health economics, and tracking down the quality of life of patients, what we are calling quality adjusted life years, the quality of life and the life years. So all these are actually based on data, and the main aim, if we're talking about the main aim, is informed decisions. We would like that the central health economics and the central health policy departments inside Ministry of Health to have enough data to support their decisions in taking actually a medication over another medication, or an intervention over another intervention, or something like the stem cell transplantation, whether I should go for a stem cell transplantation or better just to continue chemotherapy. Sometimes you'll find that even stem cell transplantation, which is 300k Egyptian pounds, will be more cost effective than chemo, which is, for example, a 50k only. Because on the long run, you do have a lot of life years. On the long run, you do have better quality of life, and the citizen will be able to be productive again in the community.
And who would be actually working within the health economics department? Would they be pharmacists or doctors? Because they will have to make decisions, and they will be very critical decisions on, as you've mentioned, calling what course of treatment should a patient have. So who would actually be working within these health economic departments?
So pharmacists currently are the one responsible for health economics in general. We are adding, now while we are speaking, we're trying to have a process of adding health economics as a specialty for pharmacists. So we'll be a health economist pharmacist. And if we're talking about the prescription or the treatment plan, of course, it's the responsibility of the physician. However, the choice of the protocol itself upfront before the hospital regimen is actually established will be part of it based on health economics. And finally, the selection of which regimen which does not deviate from the physician regimen. For example, you are talking about which type of syringe, which type of equipments, which type of MRI, for example, if we're talking bigger scale. However, it should be an integration, because the one responsible for the procurement is a pharmacist. However, he's different from the one responsible for health economics.
Yes.
And it is different from the management of the hospital, responsible, for example, finally on the treatment protocol inside the hospital. So it must be an integration between all entities inside the hospital for this actually system to work eventually. And that's what we are calling the integrated healthcare. That all healthcare and worldwide, they are trying to reach the integration between all health entities. It's not easy. It's another debatable point. And sometimes you find some tension between physicians who are trying to prescribe whatever they would like to prescribe, and then they are faced with pharmacists saying that it's not cost effective, they are not allowed to prescribe it. And we've witnessed, once we established health economics for a couple of years, a lot of debates, a lot of tension between physicians and pharmacists. However, currently I can say that's not like 3 to 4 years ago. Currently they sit together, it's one committee. And health economists should actually say that, okay, we approve this medication because it's cost effective, it's beneficial for the patient. And physicians are now convinced, and they know that the choice of a lot of treatment protocols should got one aspect of economics, not only clinical, because actually we do have limited budget as any country in the world. No country can afford having all treatments inside the formulary.
Well, so the Health Economics Department will actually be working on monitoring the activities and the services provided by the hospitals, and they will also be concerned with the quality control, the quality of the services provided by the hospitals. Now, as you've mentioned, what if the scenario happens that the department calls foul play by the hospital, or they get into a conflict of opinion regarding how to treat a patient? Who would actually be, who would they have to go back to actually make the call, or would it be up to the patient's preference? How will these sort of conflicts be resolved?
Okay, so there's a very famous quote that we all the time saying that if the system is more stronger than people, no conflicts will happen. If people are more strong than the system, a lot of conflicts will happen. So if we do have that robust system that we are discussing, it will be of less conflicting between all parties and with less tension. Having said the system, we are talking about a system that starts with assessment. Assessment of all medications at the point of registration, at the point of approving any medication. So we're not going to approve any medication which is not actually good value for money. Then if it's approved, we need a committee to have a treatment guidelines. The committee that will initiate the treatment guidelines should be clinicians, physicians, and with pharmacists and payers, budget holders, I mean.
Yes.
And then you do the reimbursement, and you do have better prices from the companies, and then you have then the treatment and the execution and the service providing, and finally you have an audit on top of all the system. That's what we call health governance. If we do have a good health governance, we're not going to be actually facing a lot of tension between all stakeholders, not only physicians and pharmacists, by the way. Add budget holders, add policymakers, add nurses, add administrative, and add patients.
Yes.
So we're trying to resolve all these conflicts by having a better system.
Yes. Well, ladies and gentlemen, Egypt has decided to increase their spending by 15% on the medical and health sector for the fiscal year 2023-2024. Let's check out this report and we'll be right back.
Minister of Finance and head of the General Authority for the Universal Health Insurance System, Mohammed Maid, announced the government plans to raise health care spending by 15% in fiscal year 2023-2024. He said allocations for the health sector in the next fiscal year amount to £397 billion, with an annual increase of 30.4%, noting that constitutional entitlement of the health sector has been fulfilled in the new budget. The minister added that health sector tops the presidential priorities in a way that contributes to the provision of good health care services as an inherent human right countrywide. Minister Mait mentioned during celebration for the issuance of Egypt's National Health Accounts report that healthcare spending has already been raised by 10% during the first 9 months of fiscal year 2022-2023. The report examines healthcare spending in Egypt, including government and citizen contributions, as well as investments in the sector. The minister stated that the universal health insurance system would be implemented in all Egyptian governorates within 10 years upon presidential mandate to compress its 15-year plan timetable. He said that providing comprehensive and integrated healthcare for all members of the Egyptian family is a dream that cannot be postponed, adding that this comes despite all global economic crises resulting from coronavirus pandemic and the war in Europe that have forced the whole world to rearrange spending priorities. Mait noted that the UHIS would be implemented in the rest of its first phases governorates, Suez, Aswan and South Sinai before the end of the current fiscal year, after the experience has succeeded in Luxor and Port Said and expanded to Ismailia. Moreover, Mait assured that for the needy families, the state's public treasury would bear the financial burdens of their sickness along with the risks and psychological consequences. He noted that his ministry aims to provide the ability to reserve medical services in the new medical system by a phone application, which helps alleviate the process on citizens. The universal health insurance system will be supported by state-of-the-art automation technologies as part of the Digital Egypt strategy, a broader national plan targeting digitization of all government services countrywide. The 6-phase healthcare scheme started experimentally in Port Said in early 2018 and later expanded to Luxor and Ismailia, with the lowest income citizens being given priority in the program's schedule. The capital, Cairo, was relegated to the final phase. Over 5 million Egyptian citizens have been registered in the country's universal health insurance system in the governorates of the first phase. The Cabinet's Information and Decision Support Center announced in December 2021, while in April 2022, Acting Minister of Health and Population Khaled Abdelghafar said that nearly 15.3 million people would be added to the country's insurance system in 2022, including farmers, seasonal workers, taxi drivers, fishermen, and construction workers, as well as transport and shipping workers.
Welcome back, ladies and gentlemen. Continuing our discussion with Dr. Anan. Now, increasing the spending by 15% for the health sector. It sounds like a very good increase, which would reflect on an improvement and development and strengthening of the health sector. But the 15%, is it because of the natural rise of the expenditures and the costs of the health services and the processes involved, or is it for the development of certain sectors or inauguration of certain hospitals or increasing the pay for the medical health workers, or is it working on the infrastructure and digitalization? I mean, where is this 15% going, and what is the best way to utilize those 15%?
Yes, or all of the above. Yeah. So mainly it's 3 things if we're talking about budget increase. First is resources. Resources, we are talking about hospitals. There is a direction coming from the need of having more health facilities and health units, as said by President Sisi during Health Execon, the conference, yes, and His Highness Minister Khaled Abdelghafar. And we are talking about human development. We're talking about training and development for the healthcare professionals. And we are talking about IT infrastructure. Because in order to have all the system we were discussing and talking about, we need a very strong IT infrastructure that can actually link and put all the health facilities together, and put as well all the health entities, because we don't have only the Ministry of Health currently. We do have a lot of entities working together, and they are not under the Minister of Health. Some units are actually having a minister on top of it, like Unified Purchase, like Egyptian Drug Authority, like the GAHAR, the Accreditation and Quality and Audit, and so on, and Universal Health Insurance Organization. So that's for resources. Another one is for process. For process, you need to spend more on having a better process of healthcare, whether you need to spend on having a unified treatment guidelines, so patients are actually treated equally and with equitable access and equitable treatment protocols all over Egypt. You need a good process from receiving the file of any pharmaceutical product or intervention, from registration till the utilization of the service by the patient. And finally, we need to spend more on enhancing outcome. And if we're talking about enhancing outcome, we're talking about data, and we are talking about measuring success, key performance indicators. And if we're talking resources, process outcome, the last, which is very important, is the prices itself.
Yes.
Because we do have increase in the budget of service providing in general inside all hospitals, and we do have an increase in the medication prices, not like the FMCG's industry, alhamdulillah, not like the food and beverage,
Yes.
because we do have a fixed pricing for medications. We're talking about an increase which is around from 20% to 40%, very rarely around 100%. Which does not match the inflation. It's
Yes.
below the inflation. However, we are discussing two things: the price of the existing medications, and that all the future medications will be actually very expensive in price. We were talking about personalized medicine. We are talking about cancer treatments. One case of prostate cancer, it was treated before with 1,000 Egyptian pounds. Currently, it can go up to around 250,000 Egyptian pounds. So that's because of the innovation in healthcare,
Yes.
the innovation in medications, and the biologics industry. We are facing currently worldwide around 900 new products from biologic existence. Biologics are very expensive.
Yes.
And in 10 years, they will be replacing the usual medications we are taking every day. So we need to increase the budget to just to cope with the increase in medication service providing, and at the same time enhance the resources process outcome, including all the presidential initiative, including all the prevention and the early detection. It's very strategic to invest in the early detection. Just when you reach 2030, you have less spending on the treatment itself, because it's actually consuming a lot. We are talking medications, for example. Medication is consuming 25% of budget. Usually, the normal is to be 12 to 14% only.
That's almost half.
Yes, exactly. Yeah.
Yes. Ladies and gentlemen, as you've heard it from Dr. Anan, I mean, a lot of programs, initiatives, early detections, primary health units, health economic departments established within the hospitals. A lot has been taken. Many steps have been taken for the development of the health sector, but as he mentioned, a lot more still needs to be done. It is a very developing, fast developing sector, and also very costly, so still a lot more will be done here in Egypt. Unfortunately, that's all the time we have for this edition of the Daily Debate. But before we go, I'd like to thank my very distinguished guest, Dr. Islam Anan, the Lecturer of Health Policy and Health Economics at Ain Shams University. Dr. Anan, thank you very much for joining us.
Thank you, Mr. Hani.
Thank you very much, sir. Ladies and gentlemen, please stay tuned for more coming up on Nile International. I'm Hani Saeed. Thanks for joining us.